The following is part 4 of a 5-part series wherein the medical intervention gender-affirming surgery is discussed from a clinical perspective. The featured physicians each have decades of medical experience with an intimate knowledge of both medicine and the medical industry. In this 4th video, there will be an investigatory discussion about the financial incentives that have possibly spurred the medical transgender movement. The intention of this series is to take an objective, scientific look at these intersex operations. As such, the content at times will be explicit, and the viewer should take precaution and use discretion when viewing.
Welcome to the Gold Report, where we inspire you to be 10% more courageous. I'm so glad you're here. Please like, share, and subscribe so you never miss an episode. Today, we welcome back Dr. Melanie Crites-Bachert for the 4th in our 5-part medical mutilation series. We will begin after this short break.
Somebody comes to us when they are the most vulnerable. We have an obligation to our patients to tell the truth as we learned it and to not politicize it. We are performing surgeries on these children that have neither the capacity to make these life-changing decisions nor the wisdom, and the only people benefiting is the medical industrial complex, because the more surgeries that are done, the more money it is made.
Whether you're talking about an 8-year-old or an 11-year-old or a 14-year-old, I don't see how you can actually derive informed consent.
We all know that we can't be getting true informed consent.
I didn't really realize, but there was a sickness that had been afflicting the profession for a long time.
Our medical industry has objectively been compromised in more ways than one.
You become familiar with the sound a mother makes when you tell her that her child is dead.
Our show today continues our 5-part series on medical mutilation. This is often referred to as gender reassignment surgery. We're pleased to welcome back Dr. Crites-Bachert, an expert in a field of medicine, and there is no one more qualified to speak on the topic of medical mutilation. She received her medical degree from the West Virginia School of Osteopathic Medicine in 2003 and completed a residency in urological surgery at the University of Medicine and Dentistry in New Jersey in 2009. She then received a fellowship training to specialize in female pelvic medicine, voiding dysfunction, and pelvic reconstructive surgery from the Cleveland Clinic, Florida. Dr. Crites-Bachert is considered an expert in treating urinary and fecal incontinence with sacral neuromodulation and has a higher than national average success rate of 93%. She became a nationally recognized consultant and proctor for sacral neuromodulation therapy as a result. Her research and implant protocol is patent pending and has established national precedent for the successful implantation of sacral neuromodulators. Additionally, Dr. Crites-Bachert is highly trained and skilled at performing pelvic organ prolapse surgery with and without mesh, and she's very skilled at surgically treating complications from previous mesh surgeries. She maintained an active role in research and tracked her own personal outcomes with pelvic reconstructive procedures. She has published long-term data results from her own patient population for treating urinary incontinence and pelvic organ prolapse as a private practice physician. We want to emphasize that although Dr. Crites-Bachert is highly qualified, she has chosen not to perform medical mutilation procedures. I think we're going to find out today that she's given up quite a financial lucrative opportunity by not doing medical mutilation procedures. There are many voices currently speaking about this topic from different perspectives. There are resources available that weigh the pros and cons. The focus of our series is to provide the necessary medical information about these procedures, information that is completely absent in public discourse, and we will be exposing the brutal physical reality of medical mutilation. Today, we will discuss the financial incentives that exist that have caused medical mutilation procedures to wildly escalate. Thank you, Dr. Crites-Bachert, for being here.
Thank you. It's a pleasure.
Thank you. I had mentioned to you once my personal experience in dealing with this, which touches a little bit on the finances. I'll talk about that more in the 5th part, which is about policy. But I will say that it was clear to me then, even as a medical student, that there was financial implications for doing or not doing. Back then in the 90s, the public was very against this. So eventually the taxpayers, which were funding the program I was at Cook County Medical Hospital, eventually the taxpayers pulled back and wouldn't fund it anymore. And then I guess it made the opportunity to create a private market for this. We've all noticed that these procedures and operations have increased enormously in the past few years. And we've heard slogans such as trans rights is human rights as a justification for providing these procedures to the public. But where is this demand coming from? Like who is pushing all of this? In other words, there's no way that humanity has changed so much in a very short time. The numbers of people who demanded these surgeries in the 90s, for example, I think it's gone up, I think about 500% since my medical school days. So I can't believe there's not some incentives behind it pushing this.
Sure. And whenever we start looking at things such as this, we always have to follow the money. And I say that coming from a background of private practice. As you know, I left my private practice a few years ago, but in private practice, as you know, hospitals are very concerned about the bottom line. And much like hospitals, being in private practice, you're also concerned about the bottom line because you have overhead, you have employees that you have to pay, you have a paycheck that you need to make. So as insurance reimbursements became less, we had to learn how to work smarter, not harder, as the old adage goes. So you would look for ways that you could maximize what you were making and reducing overhead. And hospitals play this game all the time. Anybody that is in hospital administration, the biggest conversations that they have in meetings are how to increase the bottom line. Yeah. And one of the things about these types of procedures, they tend to be some of the more lucrative procedures that physicians can perform right now.
Okay. We're just starting the subject, but again, you always have to follow the money. You always have to see when you see a big change like this in the demand. Yes, it's individual persons that are asking for it, but there's somebody behind it who's financially benefiting from it that is putting that desire out there.
And we see it in marketing all the time. Any small business, any big business, it's not just medicine. Right. We
didn't want an iPhone until we saw all the amazing marketing for the iPhone.
Yes.
So that's exactly right. So there's one company, AbbVie, which is listed as number 24 in the list of big pharma any kind of big pharma list. If you look at AbbVie, if you go to their website, of course, it shows that they really embrace the DEI, diversity, equity, inclusion model. And it seems like in the era where big pharma or medical device companies can't even buy lunch, for a doctor.
Correct.
We should talk about that for a second. My father was a doctor, and I absolutely remember that drug reps would come and visit his office and sometimes take you to lunch and other times give you very small token gifts, literally like a pen. And all that became completely outlawed. For good or for bad. You can say that they shouldn't have had that influence over doctors. On the other hand, now what they do is I think thievery on a much grander scale. They're not really visiting doctors in doctors' offices anymore. They're lobbying Congress, and then they're putting out marketing ads direct to consumers to want these products. So anyway, we live in a time when big pharma is not allowed to buy a doctor lunch or give a doctor a pen, but they can lobby Congress and they can lobby corporations to put in principles that create demand for their products. So do you feel that the average patient understands the dangers that are attendant to these procedures that are really being pushed? In other words, for me, when I see a drug ad on TV, I'm very scornful because I know that they're playing into people's fears and anxieties. And that person who's watching the commercial is afraid, and then they go to their doctor, and the doctor's very time pressured, and they probably will write a prescription for that thing, whether the person really needs it or not. And I honestly see this as an extension of that. That you're talking to somebody who may be unhappy about something, may want something, whatever, and now all of a sudden they're being presented with this very expensive for the patient, very lucrative for the doctor and the facility, with tremendous medical complications. And so, do you think that the average person even understands what they're getting into when they get into this?
From a financial standpoint, no, I don't believe so. We've certainly talked about medical complications and surgical complications, but the financial implications, patients really don't see those implications until they get the hospital bill. I mean, how many times have you had a patient? I know I've had patients that when I was in practice that would come into the office and say, "Do you know how much that surgery cost?" Because they get the bill, and if they don't have insurance, then that becomes a big financial hardship. The thing is now Medicare is covering this. Commercial insurances are now covering this. So the cost would be a copay for the patients or the deductible for the patients.
So let's get into the weeds here. So is that the situation, that our government policies like Medicare and Medicaid are covering these procedures?
Yeah.
Wow. Yeah. So when I was a medical student at Cook County Hospital, Medicaid was covering those procedures, and then the taxpayers rebelled and got angry, and they no longer funded it, and then the program disappeared. And whether that's for right or for wrong, at the end of the day, those were taxpayer dollars. That was a taxpayer. But now you're saying, so I know Medicaid is paying for it. That much I knew. I didn't know that Medicare was also getting involved. So when people are talking about Medicare going broke, I wonder if this is any part of it. I know that the Armed Forces is also paying for these surgeries. Right. Okay. So do you have dollars? What are we talking about? Like to do these surgeries?
When I was in private practice, which was just a few years ago, not even doing these
lucrative
procedures for transgender medicine. But for instance, a male may require an orchiectomy, which is castration, cutting off the testicles for certain situations, such as prostate cancer, because prostate cancer is fueled by testosterone. When you couldn't get that under control with medications and different things, you would have to perform an orchiectomy. An orchiectomy alone, just with Medicare reimbursement is anywhere from $300 to $350. That's Medicare reimbursement. If the person has commercial insurance, you can expect 150 to 200% increase over that reimbursement cost. So this was just an orchiectomy just for a situation of cancer. So this was a needed surgery. But when you start doing these procedures for something that's not an extreme situation, such as cancer, or another medical issue, you start getting into high dollars. A vaginoplasty, which is it's the big term that's used for basically recreating a vagina. So for women with pelvic organ prolapse or some other injury to the vagina that required some form of repair or reconstruction, Medicare allowable cost for that was around $1,100. And so if somebody had commercial insurance, again, you can expect 150 to 200%.
Okay, so I'm going to slow down for a second. So doing a vaginal reconstruction on a biological woman, she had trauma, she had surgery, cancer, and you had to reconstruct it. The surgeon's fee allowable by Medicare was $1,100. Private insurance, let's just honestly, it's going to be $2,000. If Medicare is $1,100, then private is probably $2,000. This was a few years ago, and that's not counting the surgery center, or the hospital, et cetera. So I just want to make sure that that's the physician fee.
That's the physician fee, not the facility fee.
Right. Okay. And so this is interesting stuff, and let's keep going.
Well, then you also have to factor in the anesthesiologist fee. So you not only have a surgeon, but you have an anesthesiologist, of course, that has a fee. So you have the anesthesiology fee. And then you have what's called a facility fee, meaning whatever facility it is performed in, the surgery is performed in, that facility gets a fee. Now let's take that a step further. Surgery centers are all the rage. So the day procedure places. Those are generally privately owned, generally by a group of physicians, and sometimes a hospital is a partner in that. Now, there are some procedures that if you do it in a surgery center, there's a higher reimbursement for doing it in a surgery center as opposed to going through the hospital. So if these surgery centers are owned, for instance, by a group of physicians, not only as a surgeon are you getting the fee from, let's say, commercial insurance or Medicare, not only as a surgeon are you getting the fee allowable for that, but then as a partner in the surgery center, every 3 to 4 months, you're getting a paycheck from the surgery center. Every partner of that surgery center is getting a paycheck because they split those costs from the profit that the surgery center brings in.
So, and another aspect, so you have the surgeon's fee for the procedure, the anesthesiologist's fee for the procedure, you have the facility fee, which is usually owned also by the doctor. So the doctors, I understand, as business owners, have financial incentives to keep their centers busy, a concept I normally don't disagree with, as long as they're offering valid things that actually help humans. When a surgeon is doing these kinds of procedures, though, it sounds like from our prior conversations that there's multiple procedures that they're doing.
Absolutely.
So it's not just an orchiectomy or castration.
Sure.
Right? So a typical bottom surgery, what would that include for a male to female?
So for male to female, you're not only getting the bottom surgery, which generally is done in a hospital because they have to stay a few days in the hospital for monitoring, bleeding and infection and the like. But beyond that, if there are other surgeries that are needed, so you have the bottom surgery.
But so what are you specifically billing for in bottom surgery?
In bottom surgery, you would, for the vaginoplasty, if they have not had an orchiectomy already, so removing the testicles, you have the fee for that. Any sort of urethral.
Is there a separate fee for moving the urethra?
Generally, that's all included in the vaginoplasty and the penile inversion surgery. Okay. So that's generally one surgery.
Do patients ever get a penile implant at the same time, or do they just wait and see if things are functional?
That would be afterwards.
Later.
That would be after everything is healed. And then you see function, and then you can do a penile implant, which typically can be done in a surgery center because that is a day procedure. Breast augmentation can be done in a surgery center and oftentimes is done. Certain facial plastic surgery can be done in a surgery center and oftentimes. So you can see where this would be very lucrative, say for a surgeon who performs bottom surgery. Hysterectomies can be done in a surgery center. So a female transitioning to a male can have a hysterectomy done in a surgery center. So that would preclude any bottom surgery, any further bottom surgery. That would be the first thing that is done. And then perhaps a few months later, then the bottom surgery would be undertaken. Then you would have any sort of facial reconstructive surgery or breast augmentation that would be done. So you can see how lucrative it would be for a surgeon who does bottom surgery and a plastic surgeon to get together and an anesthesiologist to get together and be partners in a surgery center and make this a center where these day surgeries for transgender medicine could be performed, because they're essentially getting their fee for service. They're then also getting the profit split for whatever profits come into the surgery center every few months.
And really the only obstacle to doing this might be a 20-minute telemedicine phone call that you might do with a nurse practitioner on the line who then approves all of this.
So it would seem.
Okay, so there's multiple surgeries, multiple procedures, multiple practitioners. We're talking,
and this is ongoing. These are surgeries that take place over the course of several months to several years. And then if there are revision surgeries that need to be undertaken.
And the complications that you mentioned.
Absolutely.
If you get a lot of these people are going to need surgical repairs. Like we kind of talk rapidly over things that you do a lot, like urethral stricture, because it doesn't even seem that significant compared to these. But even a urethral stricture surgery, as we were just discussing, can really lead to huge medical problems for a person.
Correct.
And you have to have those procedures as well.
And then also, we're talking about the surgical side of it. We're not even talking about the multiple follow-ups and the continued follow-ups that are required for hormonal manipulation.
So you're talking about a person who, whatever's driving them to this decision, like, whatever sorrow or sadness is driving someone into this decision, and or gender dysphoria, whatever the emotions are in the mental state. But especially the young people, they have physically healthy, functioning bodies, which are then trading for months to years of repeated surgeries. I have to share with you an experience that I had in residency. It's not about transgender, but I was doing a rotation on the pediatric intensive care unit, which is a really intense kind of experience. And I was on duty the night that a 17-year-old attempted suicide came in, and he was very, very depressed. I mean, he absolutely was suicidal. There's no question. Just, everything about it, when you have a conversation with him, it was, he had flat affect and very sad mood and all this. Anyway, he was serious about killing himself, and he threw himself off the cliffs. I was living in an area that had cliffs over the Atlantic Ocean, and he literally threw himself off the cliffs hoping he would drown. It was quite a way down, but he didn't drown when he landed there. And of course, your instinct to survive kicks in, and he's scrambling for the shore, and he gets to the shore, and eventually an ambulance comes and picks him up, brings him to the hospital, and he becomes my responsibility for the next 30 days. I'm his main provider. And I got to know him quite well, had a lot of empathy for his situation. It was a tough situation. But the day he decided to kill himself, he was an unhappy, kind of overweight 17-year-old kid with a tough social situation. Had nothing to do with transgender. But after he tried to kill himself, he was paralyzed from the waist down, and then he went into many medical complications. He ended up having ulcers that required surgery. He ended up having a partial colectomy. He lost part of his intestines and had to have a colostomy bag on the outside. And he had to be on many medications for he was in the ICU, he was on drips. By the time I left 30 days later, he was nowhere out of the woods. I understood he stayed there almost 2 more months. I remember and I relate this story because you had a person who was very depressed enough to really kill himself. And he went from being depressed to being depressed, paralyzed with a colostomy bag, and paralyzed, literally couldn't walk. This was not an improvement.
Correct.
This was not an improvement.
It did not make
this did not
situation
enhance his life.
Yes, correct.
So no one was denying the issues he went in with, but you can always make your issues worse. And so I'm here to implore the adults and the children and the young adults, adolescents who are listening to this, that whatever you're going through, understand that there's multiple ways to address it. And some of the ways that you are being exposed to can cause you tremendous pain and harm. And there's people working behind the scenes, pulling the strings that make a lot of money off the decisions that you're going to choose. And there are ethical doctors out there who are saying, no, Dr. Crites-Bachert you're qualified to do all these procedures. And in other settings, you have done these procedures. You've reconstructed female's anatomy. You've reconstructed men's anatomy. And
to make a situation better.
To make a situation better.
Yes. And that's the satisfaction of the outcome, because somebody comes to you, for instance, a female comes to you, they are just so uncomfortable from the uterus falling, the bladder falling, they're having urinary issues, they're having bowel issues, and you reconstruct it. And they come back to you after they're all healed, of course, they get over the soreness and everything from the surgery, but you restore that function. And that's what was always so satisfying to me, was to have a patient that came back in and said, my God, this was life-changing. I can't believe I waited so long to do this. I thought I had to live with this. And now it made their life better. But in these situations that you're speaking of, these procedures don't always make the situation better. And in a lot of these situations, and what we are seeing on media, as you know, these days, is that people are being promised, take this pill, take that pill, and it's going to be sunshine and rainbows and unicorns, and your life is going to be so much better. And that goes back to the conversation that we had about informed consent. You absolutely have to tell these patients, this surgery may not turn out the way that you had hoped. Much like the conversation that I would always have with my patients. Yes, we're doing this to restore function, but there's always the possibility that it's not going to turn out
Right.
the way that we had hoped, or that you
Right.
may require another surgery. It may not be 100%. It may be better, but it may not be 100%.
Right. Right. And so we've tried really hard in this series to really focus and stay sharp on the medical, and really
Absolutely.
stay away from, is this the right path or wrong path, especially if you're an
Correct.
adult. But what we're here to say is it's a very serious medical decision that you're making
Correct.
to undergo hormone therapy and undergo multiple surgeries that most of the time, in my experience, take place over years, not even over months, but take
Mhm.
place over years. So you're now investing yourself in the medical system for many years,
Mhm.
many complications, and there's people pulling the strings that are making a lot of money doing this.
Absolutely.
Not saying that sometimes it isn't benefiting some people, it may be, but make sure you're in the right cohort. Make sure that this is definitely going to benefit you. And I don't see how, my opinion is, I don't see how you can say that at age 16 without, years and years of contemplating this and understanding.
Well, and something also to consider, we've spoken about the fluctuation in hormones and how life is so volatile for teenagers. You're trading one set of hormones for another. So the situation may not get
until
better,
you get older.
and until those hormones stabilize. If you take a hormonal teenage girl and the natural hormonal fluctuations, and she thinks that she wants to be a boy, you're trading those female hormones for male hormones, which introduce a whole different set
Right.
of hormonal instability that we all know. Hormones affect our emotions. It affects our
Let's-
minds. It affects our body development. So you're trading one set of hormones for another in an already developing individual that has not fully developed yet to begin with. And then you add surgical complications and surgical implications. That's a very slippery slope, and that's a very dangerous situation.
Even though we're talking about the financial incentives today, I just want to talk for just a moment, because you mentioned about the hormones, because we hadn't talked about that so much. One of the things that really bothers me is huge thing is the fact that this stuff should be considered irreversible. Maybe you'll be in a situation where some of this could partially be reversed if you went to a lot of effort, if you do change your mind. But you just should think of this as irreversible. And one of those things, honestly, is the hormones, especially female to male. Once you get testosterone going for, I don't know how long, maybe a year, 2 years, but you have voice changes. And then if you change your mind later, that may never come back.
Correct.
And things like fertility, you've removed the uterus, you've removed the ovaries. These are, we tell 16-year-olds they can't drink.
Mm-hmm.
They're making decisions about, the rest of their life. So anyway, we're supposed to be talking about the finances today, but it's just difficult because I feel that the young people are being manipulated by big financial interests that they don't fully understand.
Correct.
So yeah. And we know as experienced doctors. Have you experienced or noticed that people who do have, let's say they don't even regret doing the surgery. Let's say they do feel it was the right path for them, but they had medical complications, for example. So they're like, yep, I'm glad I did the surgery. The gender dysphoria has improved, but I have all these medical complications. I feel like they're being silenced. And then of course, people who had regret, I know they're being silenced. They're being kind of mocked, actually. But do you, are the surgeons who operate on these people, are they giving them the respect when the complication rate you said is like 35, 45%? So these people are returning to their surgeons. Do you have any experience with the surgeons being properly attentive to patients if they're not, in a way, kind of complying with the social script?
I'm not familiar with that because I was always very responsible for my patients. If there was a complication, I wanted to be the one to take care of it. I wanted to be the one to evaluate it. And if it was something that was then beyond my scope of surgery and it required, for instance, a colorectal surgeon, I would always bring that surgeon in and I would operate with that surgeon to handle these particular complications. I have heard horror stories of physicians who are not taking care of those complications and are poo-pooing the patients, or at least the patients are feeling like they're being poo-pooed and kind of pushed off to the side, which is a very unfortunate situation. And again, goes back to the first do no harm. When as a surgeon, you are responsible for that patient from beginning to end, unless that patient chooses, to not come back to you.
I love your answer. So that is how we were taught in medicine. This is your problem, your situation, your person, your patient. And I really don't see that that's happening here because, for example, people are being approved very quickly. It's not like they're patient for a long time. Okay. Well, we will see. And we just wanted to bring to your attention just the fact that there is a lot of financial incentive going on behind the scenes. You can't have a huge shift in demand of something like this unless there's a lot of marketing going on. I do actually want to kind of compare it to the iPhone or the iPod in its day, because, before the marketing for the iPod and the iPhone, you didn't really lust for it. But so now there's a lot of financial benefits to be had by certain stakeholders if you as a patient choose to go down that road. And we're just hoping that you as a potential patient are getting the information that you need to decide if this is the right road for you. And we urge people who are young to really take a pause, because you right now, this moment, most of you have a physically healthy body, and the joy of having a physical healthy body can only really be understood if you're a person who doesn't have a physically healthy body. And we never really want you to go there voluntarily. So thank you so much, Dr. Crites-Bachert, for being with us and sharing with us your expertise and your experience also on the financial billing side of these matters.
Thank you.
If you are a physician, organization, or other entity that wants to get involved more in this issue, please send us an email at info@aflds.org. If you're a person who has questions about this and need more information, please come to our website at aflds.org, where we listed other people who are really more active in this area. So we would definitely, we would like to thank you for joining part 4 of our part 5 medical mutilation series. Today, we focused on the financial incentives in causing the rise in medical mutilation procedures. Thank you so much for joining us. Please share this. If you have a question you'd like me to answer, please let us know in the Gold Care Report. I'm sorry, on thegoldreport.com. I definitely want to hear from you. Thank you for joining us today on the Gold Report, where we encourage you to be 10% more courageous. Please like, share, and subscribe. See you next time.